So I am going to talk at a fairly basic level. We have heard some very good talks already about some predisposing factors for microbial keratitis. We are going to hear some specialist talks on fungal infection and on acanthamoeba. And so I'm going to concentrate on some things that I think you will not find in the journals and you will not find in the textbooks, but some basic ways of thinking in infection that are going to help you in your consulting rooms to not panic when you see a nasty case of infection and to try and think logically as you manage the case. So the first point to make about corneal infection is that it doesn't occur in normal eyes. This point has already been very well made by the speakers in the sessions earlier this morning. In the UK, if you break it down, about a third of our infections are contact lens related. Almost 2/3 are ocular surface disease. We have a small number of patients who are systemically unwell, particularly in intensive care units, that kind of thing, who will develop a corneal infection through exposure, those kind of situations, but it rarely occurs in normal eyes. And contact lens-related infection in young people is a big problem for us. In each country, the profile of organisms and antimicrobial drug resistance is different. And so it is important in each country to have reference centers where patients with infection are investigated when they present. And this is how we collect data about changes over time in the organisms we are seeing and about changes over time in resistance to drugs. And I think that Steve is going to talk about drug resistance and some of these aspects in his talk later today, so I won't dwell on that. But if you are working in a reference center, it's important to investigate all your patients. If you are working in a consulting room outside a reference center, using broad spectrum drugs, if there are no suspicious features in the infection, there is a reasonable case for simply treating intensively and not wasting time. What we see in the UK is predominantly aerobic bacteria. People talk about anaerobic infection. You hardly ever see it. I can hardly recall a case. And most of our cases are either gram-positives or gram-negatives with a small number of patients, about 5 to 6%, who are either acanthamoeba or fungal infection. This is the profile in the UK, and I suspect it's similar in Spain. If you go to India or the tropics, it will be different, with a greater prevalence of fungal infection. In the UK, as you probably know, we have a particular problem with acanthamoeba. And this is an interesting story. It's due to our fear of Napoleon coming to invade us in the 19th century. We thought he was going to poison the water, so they passed a law in the UK to say that every house must be built with a little reservoir in the roof. And so we have static water in our tanks in the roof. And guess what? It's full of acanthamoeba. And so this is why we think we have a particular problem with acanthamoeba in the UK. But most of our infection is straightforward. And as I say, outside a reference center, with the antibiotics we have now, we are in a beautiful phase at the moment with our broad-spectrum fluoroquinolanes. We have very little resistance to them when they're used intensively. And so I think it's reasonable to go straight to primary treatment if you have no suspicious features and a fairly straightforward-looking ulcer. But not if you're in a reference center. We have to investigate everything. Which cases do badly? Well, streptococcal infections move very fast, and large ulcers. And the large ulcers may be streptococcal. And so if you have these risk factors, then you might consider dual therapy. There's some synergy between the cefuroxime and the fluoroquinolones, and you may want to use that if you suspect a streptococcal infection, or if you have a large ulcer. And you may want to treat systemically if the ulcer is near to the margins of the cornea and near to a blood supply. But otherwise, it's intensive monotherapy, and we will come to that. If you are in a reference center, what investigations do we use? Well, the thing that has changed over the last 5-10 years is that we are using PCR on confocal microscopy on a large number of our infections now. And this adds to our ability, particularly to separate out the fungal infections, the filamentary fungi, and the acanthamoeba at an early stage. Otherwise, basic investigations, gram stain. Point to make about gram stains in a slide, which we have to tell our doctors in training when they are coming through, is it is not useful to put a bit of mucus from the tear film onto a slide and leave it there in a large sort of three-dimensional mass. The microbiologist wants to see a thin film spread out, and you need to take a microbiopsy with your corneal scrape. So think of your corneal scrape as a microbiopsy of the cornea. So you can scrape quite vigorously, and you're aiming for the base of the ulcer and the margins of the ulcer. This is where the live organisms are. Clean your slide with alcohol, let it dry in the air, and then place a thin smear of what you have picked up from your needle or your blade. We use needles in the UK, and spread that out over the slide, and then with a marker pen, draw a circle around it so it's easy for your microbiologist to find the place where they should be looking at and applying the stain. So simple practical tips about gram stain. If you suspect a fungal infection, for example, a candida, then it might be worth asking for that gram stain to be done urgently and getting the result. However, if you are pretty confident it's a bacterial infection, you don't need an urgent gram stain. As we've just said, the organisms we are dealing with are mostly aerobic, and blood agar is a blood agar plate. If you do nothing else in terms of culture, a blood agar plate is useful. But you can also use liquid media if you want to. And a word again about how to tell your doctors in training or your technicians or staff who are doing the scrapes, how to do the scrapes. First of all, remember that it's aerobic infection that we're trying to identify, and so you just spread the organisms on the surface of the gel. You don't break the gel. It's light touch here, and we're trying to get to single colonies, so we just take a biopsy or a scrape from the cornea, and then we do semicircular little streaks, 1, 2, 3, 4, and so by the time we get to the fourth streak, we're getting down to single colonies, okay? So again, no point in just putting a piece of mucus from the tear film on top of the culture plate and hoping to help that the microbiologist will be able to help you. They won't be able to help you, okay? So it's little C streaks, and spread them out, and then go back to the eye and do another line of C streaks, and that's all you need to do. So, as I say, when the patient presents, if you're in a reference center, you investigate. If you are not in a reference center and there are no suspicious features to the presentation, nothing that makes you think it might be fungal, acanthamoeba, it's reasonable to go straight to the first phase of treatment. And in your mind, I want you to separate two phases of treatment. The first phase is the sterilization phase. The priority is to kill the organisms. And so we are talking about intensive treatment. Today, it's with monotherapy in most cases with a fluoroquinolone antibiotic. And so how long do you have to treat, and how vigorously do you have to treat to sterilize the infection? Well, we have settled on 5 days, hourly by day. If you look at experimental data, rabbit models, for example, it's likely that you sterilize the cornea in 24 hours with fluoroquinolones at a high dose. You achieve very high concentrations in the tissues very quickly, but we want a wide margin for error. And the beautiful thing about fluoroquinolone antibiotics, as opposed to, say, aminoglycosides like gentamicin, tobramycin, is they're very non-toxic. We can use them quite freely at high frequencies. And so every hour by day for 5 days gives us a wide margin. But if you're asking me for the scientific basis of that in terms of animal modeling in the lab, it's probable that you could achieve the same thing with a shorter period, with a lower frequency of dose, but overkill is not a bad thing when we are trying to sterilize. So intensive treatment by day. Do you need to treat bacterial infection overnight? Probably not. Fluoroquinolones stay at above the minimum inhibitory concentration in the tear film for over 4 hours, and then there's some replication inhibition for several hours after that. There's probably little to be gained by admitting your patients to hospital or treating them overnight. 5 days, hourly treatment by day has worked well for us over the last 20 years. Systemic antibiotics, again, if the ulcer is large or close to the limbus. And if you're threatening perforation. And a question that we're sometimes asked by the junior doctors when we're saying, take a microbiopsy with your scrape, they say, well, I'm afraid of perforating the eye. Well, if you are going to perforate the eye, it may as well be when the patient is with you in hospital rather than at home later. So just be vigorous with the scrape. And then dual therapy, as we've said before, we add in a cephalosporin if there's a large ulcer or if we are worried about a streptococcal infection. When do we review the patient? You don't have to see the patient the next day or the day after. You won't learn very much by doing that. The appearance will not be changed in most cases. It may even be worse because of an inflammatory reaction to the killing of the organisms. And it's 3 or 4 days before you start to see a change. So the next time, logically, that you need to see most patients is at 5 days to a week later. You can liaise with your microbiologist 2 to 3 days out. They will have their culture results at that point, and that's reassuring for you and reassuring that you're on the right track. But you don't actually need to see the patient for 4 or 5 days. 2 very important telephone numbers you need, the patient's telephone number and your microbiologist's telephone number, because communication is extremely important in the safe treatment of corneal infection. Very basic point, but very important. And as I say, you can communicate with your microbiologist either urgently, if you suspect a fungal infection, for example, and you want to get a positive identification on the ground stain. But otherwise, it's at 48 hours. You'll have the culture results by 2 to 3 days afterwards. So when the patient comes back to you, you know what the culture situation is already, usually. What are you doing at the first review? You're trying to work out, you're trying to decide whether your patient is getting better or is static or is getting worse. What are the signs that we need to map out so we can give the doctors that maybe you may be sharing the care with if you're in a large institution some idea of whether the cornea is improved compared to when you saw them at presentation? Well, we map the cornea like this, with a little schematic drawing. And these are the things we try to map out after the scrape has been done. That's the size of the infiltrate, and we usually just draw it, and then we put 2 arrows at 90 degrees to show the dimensions in millimeters. The size of the epithelial defect, same thing. The location and an estimate of the maximum amount of corneal thinning and the height of any hypopyon. These are all things that a doctor who sees the patient after you can relate to see whether the picture is improving or it's static or getting worse, okay? But the first thing, the first sign, the first indication that a patient is getting better, and often these signs are fairly static at 5 days after the presentation. You would worry that you're not really getting anywhere. But early signs of improvement, pain. Number 1, is the patient in less pain? That is a really good clinical sign. Another thing you can look for in a severe infection is the pattern of fibrin in the anterior chamber. If the fibrin is a large diffuse cloud, then that's what you see at presentation. But when things start to improve, the fibrin contracts, and you can see there's a sort of contracted pattern to the fibrin, another really useful sign of improvement. So pain and the pattern of the fibrin, but try and teach your Okay. So now we return to our scheduled transmission, and after a nice little break, I would just very quickly say the things that I said before. Investigate if you are in a specialist center and you are collecting data that is going to help doctors all over your country. If you're in your office and the infection is straightforward, go straight to the sterilization phase of treatment, which is hourly treatment by day with a fluoroquinolone antibiotic. Review the patient at 5 days. Look to see if the patient is improving. A good sign is if the patient is in less pain. And then, when you review the patient, if the clinical progress is good, and this is the important thing here, if clinical progress is good, you are not worried about your microbiology results because the sensitivity profiles that are given relate to blood concentrations of the drug. And again, I think Steve Tuft is going to talk about this later. And we achieve very high concentrations in the tissues with intensive topical therapy. The important message is if clinical progress is good, you are doing okay. You do not need to change your treatment. And so then you can come to the second phase, which is the healing phase of treatment. And in the healing phase, we can add steroids, providing that we've got a positive culture. There have been several randomized trials of the impact of using steroids in combination with antibiotics in infection. The result is, of these trials, it probably makes very little difference to the end outcome, but it can accelerate healing and accelerate the resolution of patient comfort. So it's reasonable to use steroids if you have a positive culture, but not if you have a culture-negative infection and it could be something that is made worse by steroid use, for example, a filamentary fungal infection. Treat underlying ocular surface disease. We have already heard that microbial keratitis, in the majority of cases, occurs in an abnormal ocular surface situation, and we had a very nice talk from Juan Duran earlier this morning about the importance of treating ocular surface disease. It could be an exposure problem, it could be meibomitis. Address that in the healing phase. Reduce the antibiotics to a prophylactic dose. There is a lot of confusion about how you step down antibiotic treatment. I still see doctors reducing from hourly treatment to 2-hourly treatment to 4 times a day. You have to ask yourself why you are doing that. I think that is a confusion with what you might do to treat inflammation, where you do titrate the dose of, say, the steroids versus the inflammation. With antimicrobial drugs, you are either aiming to sterilize or you are aiming to prevent new infection, either sterilization or prophylaxis. In the healing phase, we are assuming that the cornea is sterilized, so we are simply trying to prevent superinfection, new infection in the healing phase. You can reduce to the prophylactic dose of the topical antibiotics, which for most of them is 4 times a day. Take the preservatives out of the treatment to help accelerate healing. Avoid treatment toxicity. If you are using aminoglycoside drugs, gentamicin, tobramycin, stop them and switch to a less toxic antibiotic and switch to unpreserved treatment throughout. So address ocular surface disease, bring in steroids to treat inflammation if you're culture positive, and treat underlying ocular surface problems and take the preservatives out of your treatment. All those things are going to accelerate the resolution of the infection and the patient's comfort. So if clinical progress is good, don't worry about your culture results. Supposing clinical progress is not good and you're worried that you are not making progress, well, there's 2 situations that you could be in there. Most commonly, everything is slow moving, you're just not getting the improvement you're hoping for. And occasionally you're getting continued rapid progression. So these are the two situations you need to think of if clinical progress is not good at your first review. You have to ask yourself why that could be. Check your culture results. If your culture results suggest that your antimicrobial therapy is covering the organism that you've isolated, ask yourself, is poor compliance a problem? If you have somebody who is, for example, homeless, mentally ill, living on their own, isolated, may have a drug dependency problem, all these things can lead to poor compliance. This is a situation in which you may wish to admit the patient to hospital to ensure that the drugs are actually being administered. And then check your culture results and liaise with your microbiologist. Can they help you to switch therapy? If you are having an organism that is a surprise to you, something different, and you know what the organism is, you can switch your therapy appropriately. If you didn't get any results from your primary culture, or if you didn't do a primary culture, that is the time you need to investigate with special stains, with PCR, with confocal. You really need to try everything. The question of whether you need to stop your antibiotics for 24 hours or 48 hours before you reculture to help get a positive culture result is open. But we have, in Moorfields, had the pattern of stopping our antibiotics for 24 hours to help to get a positive culture when we are reinvestigating. If your reculture is negative and you're still not improving, everything is slow moving, you are going to do a biopsy, and we will talk about that in a moment. If the situation is fast moving, if your patient is deteriorating, then you need to try empirically a switch of therapeutic line. So you might switch if there's clinical suspicion that it's a fungal infection, you might switch to antifungal therapy. If there's clinical suspicion that it's an amoebic infection, you might switch to anti-amoebic therapy empirically, without having the results of the culture to guide you. That's a reasonable step if the cornea is deteriorating fast. That's rarely the situation, by the way. So suspicious features that you might look for, of course, perineural infiltrates. These are atypical perineural infiltrates in the case of co-infection, Pseudomonas, and acanthamoeba. Features in the history of a fungal infection, perhaps, that foreign travel, particularly to a hot climate, or an injury in the farmyard, a vegetable injury, a poorly defined edge to the infiltrate or satellite lesions, all these things make you think of fungal infection. And again, liaison with the microbiologist is important. Incisional biopsy, what you are aiming to do is to include tissue that crosses the border between the ulcer and normal cornea. That's where you are most likely to find live organisms. The biopsy tissue is divided in half. Half of the tissue goes to the pathologist for histology, and half of the tissue is homogenized, liquefied, and plated out in culture by the microbiologist. The instinct for most doctors is to not involve the visual axis with the biopsy, but in this situation, it is likely that you will need to do a corneal graft to rehabilitate vision anyway, and you do not want to compromise the thickness of the tissue at the edge of the cornea if you are going to do a corneal graft later. So my recommendation is to do your biopsy centrally and accept that you will need to do a graft later. By the time you're in the situation of a deteriorating infection like this, usually that is the right thing to do. So a little counterintuitive, but that's what I would recommend. And again, effective liaison with the microbiologist is important. If the patient is still not getting better and you have a slow-moving situation, a good example would be infective crystalline keratopathy, where drug treatment has not got you any further, then excisional biopsy is the next step. And there what's quite useful is to use OCT to define the depth of the lesion and try and work with that at the time of the surgery to excise the infection en bloc, and again, send it for microbiological investigation. And the typical situation here is infective crystalline, where you have simply not made any progress, even with apparently appropriate drug treatment. Just excise the lesion. And the question of whether you need to do a full thickness graft in all keratoplasty for infection, I think, is open. The traditional teaching was that you do, but I think that many of us have shifted our emphasis, particularly in infective crystalline, for example, towards doing a lamella en bloc excision. What if you perforate? Well, you don't need to go straight to a graft. I think that we all understand that now, because the prognosis for transplantation improves if you are able to treat medically before you do your transplantation. So what you are trying to achieve here is a period of time in which you can do drug treatment before you move on to keratoplasty. How do we perform the corneal gluing? Well, you can do it at the slit lamp. And a very nice technique is the glue patch technique, which you can look up. There are videos online too. And just a couple of important practical points about gluing the cornea. First of all, less is more, okay? What is not so good is just to drop a large drop of glue onto the cornea. Very uncomfortable for the patient and pro-inflammatory, and there is a better way. So debride the epithelium around the perforation, take the epithelium away, clean up the area, and then take a spatula and a little bit of gel, the kind of thing that you might use for a contact lens on the cornea, or you can use something called, we call it KY gel in the UK, a little aqueous gel, and that helps to stick a polythene patch of surgical drape onto the spatula. And the spatula then picks up the little polythene patch, and you can punch that out with a skin trephine, 2 millimeters, 3 millimeters, 4 millimeters, and then cover this using an insulin syringe to draw up the glue into a needle, and then just with the needle, you just spread a very thin layer of glue over the patch. So long as it does not come in contact with water, the cyanoacrylate glue, it will not polymerize, and you have plenty of time. So a thin layer here, not too much gel here, because if the aqueous gel contacts the glue, you will initiate polymerization before you get to the eye. So a thin film of gel over your polythene patch, and then with a swab in one hand and your spatula in the other hand, you dry, and at the last moment, quickly put the patch on, and you can watch the glue polymerize on the cornea, and then you will be able to get good coverage, and you can close a perforation 1-2 millimeters without too much difficulty with this technique, and that buys you time to treat medically and then get a more successful outcome from your therapeutic graft. Post-infective scars. Once a patient is healed, you're looking at visual rehabilitation now. So we've done the sterilization phase, we've done the healing phase, you've got a post-infective scar. And the first thing to say about that is tell the patient to go away for 6 months, allow the tissue to remodel. You can often get quite a lot of improvement just with healing over 6 months, 8 months after the infection has passed. So patience is required. But then you're left with a scar and an irregular corneal surface. You can fit a contact lens to see how much of the problem is irregular astigmatism and how much of the problem is opacity. And that's a useful guide clinically. And a contact lens may be an acceptable solution to many patients. But if it isn't, then we are looking at laser techniques, and we can laser away the scars. We'll talk about that a bit more just now. Or we can do lamellar grafting. If you're using the femtosecond laser, superficial lamellar grafting is disappointing visually, and that's because you are applanating an uneven surface. You get an uneven interface beneath. And so more and more, I have switched over to doing deep anterior lamellar keratoplasty, and we've got a very nice technique for doing that laser-assisted now, just leaving a 6 millimeter zone down to Descemet's membrane, and that's a nice solution in these patients. But you can start with the least invasive thing and move down until you reached the end point, which is a DALC in visual rehabilitation for a scar. So another point on laser visual rehabilitation is that many patients don't want to go back to contact lenses after an infection with contact lenses, and they assume that they're not suitable for laser eye surgery. In fact, they do very well with it. And if the scar is in the periphery, LASIK is no problem. If the scar is in the center, then we are looking at a surface treatment and looking at topographic or wavefront guidance. And the mantra used to be, the story used to be, if you can't get a wavefront scan, then do a topographic guided treatment. These days, newer aberrometers do not have the problem with spot crossover that Hartmann-Shack aberrometers did have, and pyramidal aberrometers appear to be able to get a wavefront scan even from quite an irregular cornea. Post-LASIK infection, we rarely see it now. Back in 2010, when this was surveyed, it was about 1 in 3,000 cases. But I think now that we are no longer using rapid sterilization with a stagnant water bath, we are seeing it much, much less frequently. And now that people are using fluoroquinolones routinely after laser eye surgery, infection is very infrequent. It's usually the gram-positive cocci when it does occur now, but I haven't seen a case now for over 5 or 6 years. And this makes the point about the kind of organisms you see, and if it's an early presentation after LASIK, fluoroquinolones are absolutely fine. We don't really see the late presentations so often now, the atypical mycobacteria, now that we do not have rapid sterilization. One diagnostic pitfall or trap that you might want to avoid is central toxic keratopathy. You might get a call from the hospital emergency service saying an infiltrate has appeared 4 to 5 days after LASIK has been done, and this is a pattern to recognize with the opacity in the stromal bed, not in the flap, and these contracted areas of the stromal bed, so-called mud cracks. There, you do not want to do a flap lift. It will not help. That's treated conservatively. So in summary, just to draw those points together for you, and as I say, I hope this story is something that will help you in your practices and is something that you might not find in the textbooks, you might not find in the publications, but I hope it will be helpful. The key points are that infection doesn't really occur in normal eyes. Investigation is helpful if you're in a reference center. This provides the data that guides all of us about sensitivities and patterns of organisms that are occurring at a particular point in time. Divide your thinking into a sterilization phase. That is the first priority. The first week, intensive topical treatment, 5 days, hourly by day, has worked well for us. Monotherapy with a broad spectrum antibiotic, a fluoroquinolone at the moment. And then the visual rehabilitation phase, in which you're looking after ocular surface disease, taking toxicity out of treatment, treating inflammation. If a patient is not getting better, you're thinking, why is that? Are they on the wrong treatment? Are they simply not putting the treatment in? And then you're looking at reinvestigation, and at that point, close liaison with your microbiologist is extremely important. Use techniques like gluing to avoid surgery in hot eyes, and remember, surgery can be useful in slow-moving cases. And a particular example of that would be infective crystalline, but it could be a very slow-moving fungal infection as well that you might consider excising en bloc. I'll leave it there. Thank you very much for asking me, and thank you for listening to me in English as well.